Yeah. Good evening, everybody. Welcome to this session on enhanced recovery after surgery, the ERAS program. If you look at the, sort of landmark developments, they don't come every day in surgery. Laparoscopy was a huge advance, for example, and after laparoscopy came, the next advance was the advanced laparoscopy of the colon, starting with it started with the gallbladder, and then we went on to the appendix, the hernias, and then the next one was colonic resection. And the final frontier, as it were, in laparoscopy was solid organs, spleen and liver and things like that, pancreas and all that. But side by side, you will find that apart from the technique of surgery, what really makes a lot of difference to the recovery, the pain, and the metabolic stress and the like, what really makes a difference is the post-op care. And as I said, side by side with the laparoscopic advancements, we have had similar advancements in the post-op care, and the latest among them is the ERAS program. It started with ERAS for colonic surgery and has now progressed to several other organs, stomach, the esophagus, the pancreas, and the like. And talking to us about the concept of ERAS is our registrar, Pooja. I know that she's put in a lot of effort. I've seen these slides before. Over to you, Pooja, and all the best.
Thank you, sir. Good evening, respected teachers and my dear colleagues and juniors. Today we'll be covering the topic enhanced recovery after surgery. So we'll have a basic introduction, protocol guidelines and recommendations, and we'll go ahead with the components of ERAS. So surgeons have always tended towards evidence-based medicine, and the motive has always been how to adjust and enhance clinical practice to evidence-based surgical care. And this novel concept was brought ahead by Professor Henrik Kellett. He pioneered this work in the early 1990s in colorectal surgery. He named it Enhanced Recovery Program or Fast Track Surgery. The question being, why is the patient in the hospital today? So these guidelines was first published by Fearon et al. In the year 2005. And likely as Sir said, a group of surgeons from various parts of the world came together to form the ERAS Society, and they have developed protocols for various surgeries, head and neck, bariatrics, stomach, gastrointestinal. You can find them all on www.erasociety.org. So what is ERAS? It's an evidence-based care pathway designed to reduce perioperative stress, accelerate recovery after surgery, and maintain post-operative psychological function. And this is an intensive multidisciplinary approach. It involves the anesthesiologists, surgeons, nurses, and the physiotherapist. The key elements of ERAS protocols are preoperative counseling, optimization of nutrition, standard analgesic and anesthetic regimens, and early mobilization. So the guideline recommendations are based on quality of evidence. They can be high, moderate, and low. And the quality of evidence and recommendations were assessed by a grade system. So they divided it into strong recommendations and weak recommendations. So if the panel was confident and the desirable effects outweighed the undesirable effects, they termed it strong recommendations. In spite of the desirable effects overweighing the undesirable effects, if the panel was not confident, they deemed it as weak recommendations. Now, coming to the principles of ERAS, it was broadly classified into 4 categories. One was pre-admission components, pre-operative components, intraoperative components, and post-operative components. So there are totally 25 components which are divided like this. So today I'll be covering, I'll be mostly talking about ERAS protocol of colorectal surgeries. So coming to the pre-admission, it has 5 components. One is information, optimization, rehabilitation, nutrition, and anemia screening. So as you see, the rehabilitation has a very weak recommendation.
Pooja, just can I hold you for 1 sec?
Yeah, yes, sir.
Pavan, can you come in and tell me what would be the kind of studies that would tell the expert that this is a strong recommendation?
Yes, sir. Sir, I don't know, sir, exactly.
Indraja?
So the randomized control trials or meta-analysis.
Yes, very good. What would be a weak, what study would tell them it's a weak recommendation?
Retrospective studies.
All right. Or anecdotal experience or expert opinion. When there are no studies, but there are expert opinions, then you would call it a weak recommendation. When you have RCTs, reviews, meta-analysis, that would be a strong recommendation. Please go ahead, Pooja.
So the first component is pre-admission information, education and counseling. It is a very important component. It's a key element. So how does this help? It helps in reducing the anesthesia and surgery related anxiety and subsequent pain. So how do we do it? We give procedure-centered and patient-specific information. It will help the patient's preparedness, satisfaction, and overall surgical experience will be improved. It is also found to have a positive impact on the length of stay and post-operative outcomes. Modern education strategies like multimedia and virtual reality experience can also be tried. Not just the patient, but also the caregivers should meet the multidisciplinary team before the admission to the hospital to get a broader idea about the surgical experience. Coming to second component, preoperative optimization. First is risk assessment. The preoperative risk assessment scores has a very limited use because of the low level of assessment evidence. Nutrition assessment and intervention is only useful for high-risk malnourished patients. And our the basic tool of pre-optimization is to control systemic diseases like if the patient has a heart, lung, or kidney disease, or hypertension, diabetes, correction of derangements of anemia and malnutrition if present, and cessation of excessive alcohol use and smoking. So smoking is found to have an increased risk on intraoperative and post-operative complications. And a strict 4 to 8 week abstinence is required to reduce respiratory and wound complications. And how do we help the patients preoperatively? We can give them an intense counseling session and we can give them nicotine replacement therapy. Now coming to avoiding alcohol abuse, a strict abstinence of 4 weeks is recommended. Consumption of more than 2 units per day increases the rate of post-operative complications, but it has no effect on the mortality or the length of stay. Coming to the third point, rehabilitation. So the preoperative physical status poses as a risk factor for serious post-operative complications and prolonged disability. So what is rehabilitation? It is a process in the continuum of care that occurs between the time of diagnosis and the beginning of acute treatment. So here we assess the patients based on 3 things. One is physical, nutritional, and psychological status. We point out if there is any disability in the patient, and we intervene in that. So we help them with nutritional or physical or psychological interventions we give them to reduce the post-operative disability. So it helps in recovery of functional capacity and reduce complications. So what do? We give them aerobic exercises. We see the nutritional status. If the patient has protein deficiency, we give them protein supplementations or we give them immunonutrition. We give them relaxation strategies which can help them post-operatively. But the evidence is, but the recommendation is very low and further research is required to establish this as a mandatory component of ERAS. Next is preoperative nutritional care. So first we'll go to nutritional screening. How is preoperative malnutrition important? It increases postoperative morbidity, mortality, and the outcomes of surgery. And there is no consensus of how to assess preoperative nutritional status accurately. However, some papers have said that preoperative albumin concentration poses as a risk factor in morbidity and mortality. And they've given certain reference standards for nutritional screening like subjective global assessment score, patient-generated global assessment score, and malnutrition universal screening tool. So the risk of complication increases in more than 5 to 10% unintentional weight loss. And patients who are at a risk of malnutrition should be given nutritional treatment, preferably using the oral route, for a period of at least 7 to 10 days before the operation. And it helps in reducing the prevalence of infectious complications and anastomotic leak.
One sec, Pooja. One
Yes,
sec.
sir.
Pavan,
Sir,
Pooja mentioned albumin as one of the measures for nutritional assessment.
yes, sir.
What does it measure? Visceral protein or somatic protein?
Sir, somatic proteins.
Yeah, we have had so many classes on nutrition, and you choose the wrong one. And we have also discussed why albumin may not be a great indicator of the
Yes, sir.
nutritional status. Can you tell me why?
Sir, in inflammatory conditions or some infectious conditions also it may got elevated, sir. So,
Elevated?
or that means
Okay. I'll have to give you this assignment, only you. Okay.
okay, sir.
I need you to tell me everything about albumin.
Okay, sir.
Okay. Everything about albumin and share it in the group, because you got things wrong, and while I appreciate that you don't waste time, but your I don't knows are very frequent, and if you come prepared for these classes, that wouldn't happen. So please make sure that you read up about albumin as an indicator for nutritional assessment and let us know about it. Pooja, can you tell us why albumin may not be a great indicator?
Yes, sir. Sir, actually, pre-albumin is better than albumin, like we've already discussed in the previous class, because
Yes.
the half-life of albumin is over 20 days,
Correct.
and pre-albumin is just 2 days. So it poses as a better indicator for.
Correct. And as I said, these inflammatory conditions will
Yes.
artificially reduce the albumin.
Albumin levels.
Okay. Yeah, go on.
So next is coming to the management of anemia. Can someone tell me what is anemia? Can you define anemia in males and females?
Call out a particular name.
Indraja?
Hello.
Go on, Indraja.
So according to the WHO guidelines, in men they mention less than 13 grams per deciliter, and females less than 12 grams per deciliter. Sir. Is it correct?
Yes, like she said, sir.
Yeah.
Anemia is defined as less than 13 gram per deciliter in men and less than 12 gram per deciliter in women. But they also say that in women, less than 13 gram per deciliter with iron deficiency can also be considered as anemia. So why is iron deficiency important? Pawan, can you tell me?
Madam, so RBC, so post-operatively fast recovery, oxygen delivery.
Go on, Pooja. Tell them
Yes,
the answer
sir.
and yeah.
So this iron deficiency has a serious implication, sir. If there is a blood loss, so it helps to see the potential to restore the hemoglobin through hemopoiesis when there is an ongoing blood loss. So iron deficiency is an important component to measure. So the most specific and sensitive test here is serum ferritin concentration, and less than 30 microgram per liter is deemed as iron deficiency. So what are the factors causing anemia? One is vitamin B12 or folate deficiency, anemia of chronic disease, acute or chronic blood loss. And it is very essential to optimize a patient's hemoglobin concentration preoperatively. And like we have already discussed in the previous class, administration of blood products perioperatively increase complications and have a long-term impact. So studies have said that there is an increase in organ space and surgical site infection. A 4-year mortality rate is increased by 10%, and it is also an independent risk factor for poor short and long-term outcomes.
All right. One sec, Pooja. So if preoperative or perioperative blood transfusion is a risk factor, what are the tools at the disposal of a surgeon to increase the hemoglobin with or manage anemia without giving a blood transfusion? Can you enlighten us, please, Vinod?
Hello, sir.
Just mention two processes or two things that surgeons can do to improve the hemoglobin status without resorting to blood transfusion.
Immediately, sir.
Whatever.
Sir, basically, as before, if it is less than 6, it is required even in anemia. Otherwise, it is not generally it's required. And even the saturations, if the amount of oxygen carrying transport, we can increase by supplementing the oxygen also.
Life is getting a bit complicated. See, I'm saying I deliberately didn't mention the word immediately. I just as somebody is anemic, you have to operate on them. It is not an emergency. What are the tools that you have to manage this case of anemia without blood transfusion? Just mention 2 or 3 things. Yeah, go on. Just think it's common sense. It's not rocket science. Go on.
Iron infusion, sir.
Iron infusion, total iron infusion.
Sir,
how long?
even with iron infusion also, it requires at least 4 weeks to increase.
Yeah, it need not necessarily be 4. It could happen as early as 2, but iron infusion is one of them. Okay. What else?
Okay.
What else can be done? Can something be done on the table? You can. Cell saving techniques. Have you heard of it?
No, sir.
No? Then you have to read up about it and let us know. It's an assignment for all the whole class. Okay.
Yes.
What are cell savers which can be used intraoperatively? And of course, if the anemia is not very big, it doesn't apply directly to my question. If you need blood at the time of surgery and the patient is not too anemic, you can have an auto transfusion. You can draw blood and keep it, and then you can let his body recover to his original status and then use that blood for transfusion. Not
For
applicable.
malignancies generally.
Sorry?
Generally, this technique is used in malignancies, sir.
Not necessarily malignancy. Any patient, you can use auto transfusion. All right. So the 3 things, tools at your disposal in appropriate cases: total iron infusion, auto transfusion, and cell savers on the table. All right. Go on, Pooja.
Yes.
Sir, one
Yeah, go on.
minute, sir. Pooja, you mentioned all the causes for iron deficiency or anemia. The
Yes,
important
sir.
thing is this one. There will be cachexia and also marrow suppression, especially
sir.
with malignancies. So that is
Malignancies.
another major contributor for anemias, in
Yes.
addition to others.
Yes.
And this theory about blood transfusions affecting the patient's long-term outcomes in terms of cancer has been debunked. I don't think that is, and unless the patients, for example, Jehovah's Witness or whatever, who refuse transfusion, then whatever sir said about other alternatives is good. But if the patient refuses, of course, we have to respect their wishes. Otherwise, as far as immunologic mechanisms causing blood transfusion causing problems has now been disproved, I think.
I'm not sure about that, Ravi. I still think one has to consider about possible immunosuppression from perioperative blood transfusions.
Yes, sir. Yes, but the thing is, I have, because when coordinated the blood, I read extensively about it.
Yeah.
There is very little literature to support that evidence now.
Okay.
But I think it does make sense. If you can avoid blood transfusion, you should.
Yeah. Okay, go ahead, Pooja. Yeah.
So ASA recommends a minimum of hemoglobin of 6 to 10 gram per deciliter based on patients' comorbidities and types of surgery. However, for high-risk patients, to avoid complications, the hemoglobin should be maintained more than 8 gram per deciliter. So how do we increase hemoglobin? Sir has already said, oral IV iron therapy is much better than oral therapy, and studies have said that hemoglobin increase of 8 gram per liter over 8 days following IV ferric carboxymaltose 15 milligram per kilogram given over a single dose over 15 days. Now the next component is preoperative. Here we'll be discussing about prevention of nausea and vomiting, selective pre-medication, prophylactic antibiotics, no bowel preparation, maintaining euvolemia, no fasting, and carbohydrate drink. All of these have strong recommendations. So first we'll be talking about prevention of PONV, that is post-operative nausea and vomiting. How does it affect the patient? It causes dehydration, it delays the return of nutritional intake, placement of NG tube, increases the IVF in the post-operative period, it prolongs the hospital stay, and in turn increases the healthcare cost. It is multifactorial. It can be patient-related, anesthesia-related, and surgery-related. So patient-related, the female gender is more affected, non-smokers and patients who have had history of motion sickness. In anesthesia-related, usage of high volatile anesthetic gases like nitrous oxide and liberal use of opioids can also increase PONV. And type and duration of surgery are major causes of PONV. Now, coming to the prediction of PONV, there is something called Koivu-Ranta score and Apfel simplification of this score, which can predict the post-operative nausea and vomiting. Alternative strategies are administration of antiemetic prophylaxis. There are certain first-line drugs and second-line drugs. First-line drugs being dopamine D2 antagonist, a 5-HT3 antagonist, which is commonly used, ondansetron, and corticosteroids, dexamethasone. The multimodal administration reduces the postoperative nausea and vomiting by more than 25%. Second-line drugs like antihistamines, anticholinergics, and D2 antagonists can also be used, but their uses are very limited because of their side effects. So studies have said that preoperative administration of gabapentin and pregabalin also significantly reduces nausea and vomiting. However, they have few side effects like visual disturbances and sedation. And prophylactic analgesia of IV paracetamol decreases the pain. In turn, it decreases the postoperative nausea and vomiting. Also, high inspired oxygen concentration has also been found helpful. And alternative therapies like music therapy, aromatherapy, acupuncture, hypnosis, and relaxation techniques are the latest techniques which can be used preoperatively to help reduce postoperative nausea. Coming to pre-anesthetic medications, there are basically two strategies. One is anxiolytic strategies and one is opioid-sparing multimodal approach. Now, how do we reduce the anxiety? One, we can give them anxiolytic sedatives, or as we have already discussed, we have to educate them about the procedure and the anything related to the surgery. So the sedatives, the usual options are benzodiazepines and melatonin. Benzodiazepines are less preferred because they cause psychomotor and cognitive impairment side effects. And also it is strongly not recommended in elderly patients. In opioid-sparing multimodal approach, there are three drugs that we can use. One is paracetamol, NSAIDs, and gabapentinoids. Gabapentinoids are oral formulations and they are given in single lowest dose. Coming to antibiotic prophylaxis and skin preparation, IV antibiotic prophylaxis should be given 60 minutes before incision, and repeated administration has not been found to be useful. SSI was significantly reduced when given as oral, systemic, and with mechanical bowel preparation versus patients who received systemic antibiotics alone with mechanical bowel preparation. And also skin disinfection with chlorhexidine has found to have reduced incidence of SSI. Routine hair removal before surgery does not reduce surgical site infection, but if deemed necessary, we can do it immediately before surgery by clippers and not by razors. Coming to bowel preparation, it is best avoided in colonic surgeries, but it is found beneficial for rectal surgeries. What does this bowel preparation do? It causes dehydration, it causes electrolyte imbalance, and it causes discomfort for the patient. And either giving the bowel preparation or not giving the bowel preparation, the literature says there is no difference in anastomotic leak rates, surgical site infection, intra-abdominal collection, mortality, reoperation, or hospital length of stay. Next, coming to preoperative fluid and electrolyte therapy. So the patient should reach the operation theater in a euvolemic state. So preoperatively, we should assess the patient's electrolyte deficits, and and all the deficits, either excess or deficit, should be correct preoperatively. And we should ensure to avoid prolonged preoperative fasting, and mechanical bowel preparation should be avoided. And clear liquids, best if given carbohydrate drinks. Patient can be given up to 2 hours prior to induction of anesthesia. Now coming to preoperative fasting and carbohydrate loading, non-alcoholic clear liquids can be given up to 2 hours, and a light meal can be given up to 6 hours before the induction of anesthesia. How do we give it? We can give complex maltodextrin, 800 ml in the evening before surgery, and 400 ml 2 to 3 hours before the induction of anesthesia. How does it help? It reduces the catabolic response that is caused by overnight fasting and the surgery. But in patients with delayed gastric emptying and patients undergoing emergency operations or emergency patients, we have to let them fast overnight, or they should have at least a minimum of 6 hours fasting before surgery. Now, what are the advantages? It increases the preoperative well-being of the patient. It maintains the lean body mass and increases the muscle strength. It increases the post-op peripheral insulin sensitivity and has beneficial cardiac effects. And it helps in reducing the post-operative insulin requirement. It reduces the chances of hypoglycemia, length of stay, passage of flatus, post-operative insulin resistance, and protein breakdown.
Just one sec, Pooja. We'll take a little break. All right, Nikita, she mentioned about a lot of things in the preoperative state. In you've been seeing patients. I'm sure you had some colonic surgery, another major surgery from the time you started?
One case, sir.
That's good enough. Yeah. So that's good enough. So what are the things that were recommended in an ERAS that we did not do in the preoperative phase? In other words, I'm trying to see how much you have absorbed about what are the things to be done in the pre-op phase. Yeah. Was there extensive pre-op counseling of the patient?
No, sir.
I'm helping
not
you.
Extensive.
Yeah,
Not extensive, sir.
Yeah. So that's one thing. It's not exclusive to Sagar. Even in my practice, if I had to start ERAS tomorrow, I'll have to definitely increase the amount. We do a lot of counseling, but still I think it falls short of the ERAS standards. Do we routinely give them prehabilitation help?
No, sir.
Yeah. Mobilization, preoperative chest physio, preoperative incentive spirometry, preoperative. I'm not talking about post. Okay.
Yes, sir.
So these are the things that we should seriously consider. We generally do a nutritional status adequately. We look at their albumin definitely. We look at their weight and a rough, if not a very formal, at least a rough nutritional assessment. What are the things that are lacking as far as the anesthetic issues are concerned?
Compliance and skills. I mean, sir, the interdepartmental coordination for all the.
No, that's general. What are the things that you think anesthetist should do, which is not normally done? Is there a routine pre-anesthetic medication? Is there a routine attention to avoiding PONV?
No, sir.
No, that's again a thing that we should be doing. All right. So these are the things that come to my mind offhand. And as you can see, none of them is beyond us. It's just that we have to pay attention to what we're doing. Okay. Before I ask other questions, I'll come to you in a minute, Ravi. I'll just attend to the chat box. Any role for erythropoietin in anemia? Pooja?
Sir, day 3 reticulocytosis begins at day 3 to 5, sir. And the literature says that there is no point of giving an erythropoietin.
Other than for people with CKD and things like that, I don't think for a routine post-pre-op operative patient, it has a role. Nishant asks about pre-op PCT or at the start of surgery.
Pre-op PCT can be given.
Yeah, pre-op is actually not required. I think at the start of surgery is good enough, or intraoperative analgesia. See, many people give them narcotic analgesics intraoperatively, and that is something that one can avoid. And that's why you have to think of PCT rather than narcotics. In fact, when we did a colectomy recently, we were having this very discussion with the anesthetist. Why do we still give bowel preparation if there is no advantage versus no bowel preparation? I give bowel preparation, and I'll give my reasons later. Pooja.
Yes, sir, even I had that same doubt. We also follow the same thing. We give mechanical bowel preparation.
Ravi.
Sir, I think this debate, I think, will keep on going.
Yeah.
But basically, the bowel, if you look at the history of bowel preparation, there is an article in Lancet in 1971, which recommended bowel preparation because it seemed to be a logical thing to do, have a clean bowel so that your anastomosis will be. So then at 1985, somebody started questioning this, maybe it's a dogma, and then they had several randomized control trials, which none of them reached statistical significance. And ultimately, the meta-analysis of multiple randomized control trials did show that not only was mechanical bowel preparation not beneficial, but some of the complications were more in the patients who had mechanical bowel preparation. But so this now for colonic surgeries, it is widely accepted that mechanical bowel preparation may not be necessary. But in rectal cancers, it does become necessary because of the fecal column that stays in the left colon, which can adversely affect your anastomosis in the first 48, 72 hours, and thereby may be causing anastomotic leak. So I think the rectal cancers, especially where there is luminal compromise, it does make sense to give bowel preparation in those people. I think that
I-
is
I'll
where
tell
we are.
you, even the meta-analysis of large series, in fact, I've done some recent reading up about it, shows that while mechanical bowel preparation alone may not make much difference, MBP combined with antibiotic prophylaxis, there is a decreased systemic sepsis rate and a shortened LOS compared to mechanical bowel preparation alone. This is debatable. I'm not questioning it, but there are several studies which show that if you add antibiotic prophylaxis to MBP, it helps. And the second big reason, again proved by data, is that while bowel preparation does not reduce the incidence of anastomotic leak, it does reduce the consequences of an anastomotic leak. So if you have a leak with a loaded bowel, then when the leak is, if the leak does occur, then the consequences are more severe if you do not have a mechanical bowel preparation. That is why I still continue to do it. But yes, there are many units which do not do a mechanical bowel preparation. But I have given you my two bits, my two reasons for why I would do it. And Nishant adds, it is less messy and easier to handle versus a loaded colon, particularly in a lap surgery. I would tend to agree with him, but you may argue that you must learn to deal with it, even with a loaded colon. But as I said, the jury is still out. I think it's still a little debatable, and different surgeons, choose different methods. None of them is really wrong. Yeah, go on, Ravi.
Just like we had this debate about the abdominal wall reconstruction in our surgical class one. Correct. There was a debate in Association of Coloproctology. Again, the consensus is not reached. I think this debate will rumble on. I think there is no definitive answer. As you said, it is surgeon's preference.
Yeah, there are a few topics like this. As Ravi said, AWR versus other methods, bowel preparation, colloids versus crystalloids in resuscitation, things like that. Things go on. All right, Pooja, please carry on.
One more point that you about the anesthetic input in as far as this is concerned. The world has moved towards the obligatory underhydration, especially in the perioperative period, which the anesthetists have to come on board. They still seem to keep on putting up liquid after pints after pints, which probably may not be necessary. So that is another thing we have to educate them about when we are doing the EOS.
All right, go on, Pooja.
The next principle is intraoperative management. Here we'll be dealing with the standard anesthetic protocol, fluid normovolemia, normothermia, minimal invasive surgery, and no drainage, all of which have strong recommendations. So first, standard anesthetic protocol. Long-acting benzodiazepines are always best when avoided. We should resort to choose the usage of a short-acting general anesthetic agents like propofol and short-acting opioids like fentanyl, alfentanil, and zopentane. Propofol, when given total intravenously, has found to have effects on reducing the PON. Nitrous oxide is best avoided because they have delayed effects on the bowel. Now, coming to laparoscopic surgery, there is a term named deep block. So what happens in laparoscopic surgery and robotic surgery is that we are insufflating the peritoneum with carbon dioxide. So what happens there? There is worsening of the cardiac function. It impedes the ventilatory support, ventilation, and decreases the blood flow to the kidneys. So to avoid that, there is something called deep block, which helps in maintaining muscle relaxation of the abdominal muscles, which may allow operating at lower pressure while maintaining intra-abdominal space for surgery. So how does it help? It helps in reduction of the physiological effects of pneumoperitoneum, that is reduction in aortic afterload. It improves the renal blood flow and lowers peak airway ventilatory pressures. Next, coming to neuromuscular monitoring, it is a standard of care when combined with acceleromyography. So reversal of neuromuscular block to train of 4 ratio should be 90% to avoid the residual paralysis and risk of post-operative pulmonary complications. Normally used, regularly used reversals are Sigma-Dex and Neostic. Now coming to intraoperative fluid and electrolyte therapy. The main aim is to maintain intravascular volume, cardiac output, and tissue perfusion while avoiding salt and water overload. A maintenance fluid of 1 to 4 ml per kg per hour should be given to patients when indicated. Or we have to give in patients who have a definitive indication, we have to give them boluses of cold-directed fluid therapy, where colloids are preferred over crystalloids. And it helps in reduction of length of stay, morbidity, intensive care length of stay, and time of passage of feces is reduced. When patients have arterial hypotension, they are usually treated with vasopressors, and when there is reduced cardiac contractility, we treat them with inotropes. But most important thing is that the perioperative weight gain should not be more than 2.5 kilograms.
Just one sec, Pooja. Praveen, why do you think this perioperative weight gain occurs?
Because patient will be immobile, sir.
Mm-hmm. What has mobility got to
And,
do with it?
uh,
Just go back one slide, Pooja. Yeah. Patient is 70 kilos. When he goes on the table and when he comes out, you measure him, it will be 73 kilos. Where did those 3 kilos come from?
fluid overload, sir,
Correct.
during the surgery.
So how much fluid do you think is overloaded by if he has 3 kilos? Why is there silence in this? If you have
3
3
liters, sir.
Thank you. Ashte. Very simple.
Okay,
There's
sir.
no,
Okay.
no trick. I don't ask any tricky questions, but I just want to make sure that you guys are thinking. Why do I know?
Yes,
Why do I want you to know what is that amount of extra fluid? Why do I want you to know that? You will have to dry him up. Dry
Yes,
him
sir.
up in the post-op period, right? Otherwise, he will be
Yes, sir.
overloaded and your ERAS will fail. So how do you
Yes,
know
sir.
whether you're drying him up or you're actually adding or you're doing nothing? How do you know?
Sir, we monitor the input and output, sir.
Thank you. That's all there is to it. I just want you to be aware as a resident when you go. We told you about our intake output measurement.
Yes,
So
sir.
you should be aware that you should dry somebody out, and if so, if you feel that your input and output are the same when you're expected to dry him out, then you're not doing something right. All
Yes,
right.
sir.
So
Yes,
your
sir.
output must be more than your input.
Input. Yes,
That
sir.
is the importance of doing this scientifically. Go on, Pooja.
Yes, sir.
Yeah.
So preventing intraoperative hypothermia.
Yeah.
The general and neuraxial anesthesia affect thermoregulation. How do they affect the thermoregulation? It impairs the vasoconstriction and causes shivering. So what happens when the patient shivers? The temperature redistribution occurs from the core to the periphery. So it leads to increased heat loss. So the median temperature of 36.5 degrees Celsius has found to have an increased blood loss rate by 16% and the rate of blood transfusion increases by 22%. Apart from vasoconstriction, it can also cause myocardial ischemia. It can cause cardiac arrhythmias. There is an increased afterload. Oxygen consumption increases. Stay in post anesthetic care unit increases. Rate of infection, hospital stay. It also decreases the splanchnic blood flow and the drug biotransformation.
Praveen, one sec. Would it worry you that it reduces the splanchnic blood flow, Praveen, after your colonic surgery?
Sir, I don't know exactly, sir.
You don't know. Okay. Indraja.
Sir?
Now, Pooja mentioned that hypothermia decreases the splanchnic blood flow. Would it worry you as a surgeon if you have done colonic surgery and the splanchnic blood flow is in some way compromised?
Blood supply to the anastomotic site.
Excellent. All right.
Yes.
So
Yes.
what is another thing that reduces hypothermia is one. And what is another thing that reduces splanchnic blood flow significantly in the post-op phase, which you would try and avoid if at all possible? Like hypotension, something else. I gave the answer.
Sorry.
Sadly. Like hypothermia, I meant hypotension and the use of inotropes.
Okay.
All right. That's another
Yes,
thing
sir.
you would like to avoid. Go on, Pooja.
Okay.
So who are the patients at risk? Patients with ASA of 2 to 5, and preoperatively the patient has hypothermia. Patients which who will undergo regional and general anesthesia. Patients to undergo major surgery, and patients who are at a high risk of developing serious complications. Now, how do we cope with this hypothermia? So,
Pooja,
methods. Yes,
you
sir.
have to add one very important who are at risk. Old people of old age. I think
Yes,
they are
sir.
more prone to developing hypothermia than
Yes.
other people.
Extremes of age, actually.
Extremes of
Yeah,
age.
extremes of age. Correct. Yeah. Correct, sir. I think that,
Yeah.
yeah,
Go
that's
on.
absolutely right. Yeah.
So, how do we conserve the body temperature? So we can give warm and humidify the anesthetic gases, warming IV and irrigation fluids, or we can give forced air warming blankets and devices. In laparoscopic surgeries, hypothermia is mainly due to cold and dry carbon dioxide. Now, studies have shown that we can give warm and humidified carbon dioxide to prevent hypothermia. Coming to the surgical axis, the standard of care today is minimal invasive surgeries, and it is the independent predictor of good outcome. It helps in early mobilization and recovery. It also helps in decreasing the trauma and immunological impact of surgery. It decreases the length of stay, blood loss, complications, pain and opioid requirements. It has less impact on fluid shifts, less postoperative ileus, less wound-related complications like incisional hernia, and less adhesions. Next, coming to drainage of peritoneal cavity and pelvis. It shows no effect on clinical outcome. It is only kept as an indicator of any anastomotic leak if present, and should never be routinely used. So can I go ahead, sir?
Yeah, please go ahead. Before that, please note that Nishant has given you a link for an article that he and I wrote on bowel preparation. Okay, it's a short article. Please click on that and you can read up and learn about it. He again raises the issue of colloids over crystalloids. That's very debatable, Nishant. As you have seen, I personally do not favor colloids, but some people do. Their only argument is that they'll reduce the volume of liquids that they give. But I think you can equally manage it with the crystalloids as well. But this debate is likely to continue some time now. Yes, Ravi.
Sir, but when I again did this, moderated this one blood transfusion and it's one, I looked extensively at that. Now it seems that the debate is finally settling in favor of crystalloids.
Yeah.
I think you should have good reason to give colloids. Crystalloids is the preferred solution.
I would agree with that. Yeah.
Yeah.
Go on, Pooja.
Now, coming to the last component of post-operative component, we'll be dealing with no gastric drainage, multimodal anesthesia, thromboprophylaxis, fluid normovolemia, urinary catheterization, prevent hyperglycemia and postoperative ileus, postoperative nutrition, and early mobilization, all of which have very strong recommendations. Now, coming to nasogastric intubation, why do we give a NG tube to a patient? It only helps in postoperative if at all the patient has discomfort from gastric distension or if the patient has vomiting. And it also has a role in refractive postoperative ileus, only to decompress the stomach and to reduce risk of aspiration. And prolonged NG tube insertion causes increased occurrence of pharyngolaryngitis and respiratory infection. Also, it delays nutrition in the postoperative period. Hence, it should be removed before the reversal of anesthesia. Coming to postoperative analgesia. First is multimodal analgesia. So patients can be treated with commonly, which we usually use, paracetamol and NSAIDs along with epidural anesthesia. Also, tab block, surgical and port site infiltration. So let's discuss about
one sec.
Yes.
I would add operative site infusion. It has been shown to be equivalent to epidural anesthesia with our own work and data. So, of course, we're talking about laparoscopy here mostly when we talk about ERAS, and of course, there is it's only port site infiltration. But if you have an open operation, there's nothing that prevents you from doing ERAS in open surgery, even though the success rate may be a little lower than that of laparoscopic surgery. But if you have an open wound, you can consider an infusion of the wound with local anesthetic. Go on.
Okay. Yeah. So first we'll discuss about the epidural blockade. It helps to minimize neuroendocrine and catabolic response to injury. It reduces the insulin resistance and minimizes post-operative protein breakdown. The gold standard today is thoracic epidural analgesia. We usually use local anesthetics and lyophilized opioids for this. The disadvantages being a high epidural failure, not high, but epidural failure rate of 22 to 32% and post-operative arterial hypotension. So in patients, so usually the thoracic epidural analgesia gives analgesia to dermatomes T7 to T10. And when patients are undergoing a perineal surgery, they are supplemented by another analgesia. So usually a lumbar epidural analgesia is not recommended because it provides insufficient upper sensory blockage for the incision. There is very lack of blockade of sympathetic fibers. There is risk of lower limb motor block and there is high chances of urinary retention. The advantages of an epidural blockade is it accelerates recovery of bowel function and it reduces respiratory and cardiac complications. Now, coming to spinal anesthesia, it has a high efficacy and relatively low complication profile than an epidural. Local anesthetic like bupivacaine and long-acting opioids are usually used. It reduces the endocrine metabolic stress response only for the duration until which the local anesthetic acts, and then it comes back to normal. We can mobilize the patient as soon after the surgery once the motor block has worn off. Next, coming to lidocaine infusions, it reduces the opioid use and incidence of nausea. It can be given at a rate of 1.5 to 3 ml per kg per hour. It reduces incidence of postoperative ileus, but it has side effects like tinnitus, blurring of vision, dizziness, tongue paresthesia, and periodal tingling. Next, coming to abdominal wall blocks, we ourselves have done a study on this. So, which is laparoscopic versus USG guided. So, transversus abdominis plane block has been widely studied these days. It can be 2-point or 4-point. You can give it USG guided or laparoscopic visualized. It covers around T10 to L1 dermatomes. It lessens the usage of opioid. There is faster resumption of GI tract function and recovery. Commonly used are bupivacaine and ropivacaine. Now coming to thromboprophylaxis. So in patients undergoing colorectal surgery without any thromboprophylaxis coverage, 30% are found to have asymptomatic DVT. So thromboprophylaxis can be given as mechanical or pharmacological. How do we give mechanical? We give compression stockings, that is TET stockings, or intermittent pneumatic compressions. Pharmacological, we can give LMWH or unfractionated heparin. A single dose is sufficient. Now coming to extended thromboprophylaxis, that is extended, that is once we discharge the patient up to 28 days post-surgery, whether the LMWH has to be continued or given or not. Because now there is there's a shift has trend, there's a trend, like it has shifted from open surgery to minimal invasive surgeries. So sir, what do you think, sir? Should it be given?
Yeah, let me first ask Pavan again, what is the difference between a normal thromboprophylaxis and an extended thromboprophylaxis?
Sir, normal thromboprophylaxis means compressions on stockings, and mechanical
duration. It only applies to duration. Okay, duration of whatever you give. Yes. What's the difference between normal and extended? In spite of my lecture, you can say I don't know.
Yes.
You don't know. Okay, Indraja.
Sir, normal thromboprophylaxis means like during the hospital stay will give.
Okay. And
extended means during the discharge will convert to oral.
Okay. And how long is it given for? 4 to 6 weeks. Yeah, 4 to 6 weeks. What is the rationale for it?
I'm not sure, sir.
Not sure. Look up again, I can give you the answer, but I want you to look up and give me an answer tomorrow, all of you. What is the rationale for extended thromboprophylaxis? Put it in the group, okay? Yes. And Nikita asks difference between infusion and infiltration. Pooja, do you want to take that?
Infusion is
what is the difference between infiltration and infusion?
Local infiltration is just like we give like limited amounts, sir, like 10 ml, like locally. And infusion is continuously given for a short time.
Infiltration is a one-time injection, Nikita. When you close the abdomen or these port sites, you just give it there. The long-acting ones like bupivacaine, for example, work for about 6 hours. But then an infusion is when you put a catheter into the wound. It's not done for laparoscopic ports, but for open laparotomy wounds, for open surgery and laparotomy wounds, you leave a catheter inside in the subcutaneous plane of the wound and use a pump and continuously give the same local anesthetic agent over a period of time, maybe 48 hours. And it will give them very good analgesia. It is considered equivalent to epidural. The advantages are that it can be done by surgeons themselves. You don't need the expertise of having to put an epidural, and it is less expensive because putting a epidural itself costs money. Nishant asks when to give Clexane, pre-op or post-op? If post-op, how many hours after surgery? Pooja, do you want to take that?
Sir, we can start immediately after surgery, sir.
Immediately, as soon as the patient goes back?
Sir, I'm not sure.
Not sure. The real evidence is that even if you give it at the time of induction of anesthesia, like you give the antibiotic, for example, prophylactic antibiotic, you can start your prophylactic Clexane as well. But it has been shown that if you give it 12 hours after you finish the operation as well, that its effectivity is equally good, with the only rider that the patient should not have had a long preoperative immobilized state. If somebody is elderly and bedridden and then you take him to surgery, then post-op is not good enough because he's already prone to surgery, prone to DVT in the ward itself. So ideally, those people, even medical patients, not just surgical patients, if they're bedridden, they must have thromboprophylaxis in the ward if they're immobilized. Other than that, even if you give it 12 hours after the surgery, their DVT rate is about the same as giving it, but it can be given even at the time of induction. But by and large, just like we talked about bowel preparation, somehow you feel that you may end up with more intraoperative bleeding and you hesitate to give Clexane on the table, but it can be given. It's shown to be not harmful. Ravi, you have any comments?
Yeah, I think that's right. I think for the clue for all the students is the the grading of the risk of DVT, and that is where you have to look at where you give short course and or extended thromboprophylaxis.
All right. Can I, it's very nice that we have Shrikant, Ramkrishna, and Niranjan also. Can I invite comments from Shrikant about this, please, about prophylaxis? All right. Ramkrishna?
Sir, here we rarely use it, sir, only for very major surgeries. For regular surgery, we don't use prophylaxis.
Yeah, but if you do colons and prolonged operations.
Case, yes, sir. We
unmute Ramkrishna. I think you have muted yourself.
Patient is shifted to ward, we give.
Yeah, soon after shifted to the ward. Niranjan?
Sir, same thing, sir. In except in bariatrics, they propose to give it 12 hours before surgery.
Yeah.
That's the only thing. Other than that, the same thing.
Yeah. Go on, Pooja.
So what about this extended thromboprophylaxis, sir? Your thoughts?
Yeah, I don't use it unless the patient is excessively prone for DVT, and these high-risk patients are those who have had DVTs before, or who have a hypercoagulable state, established hypercoagulable state, or those whom I do not expect to be mobilized. There are some people who don't get out of bed at all, obese, high-risk patients. So if I'm not confident that they're up and about, then I would recommend, we have done it in the past as well, extended prophylaxis. I give it for 4 weeks after surgery.
Normally, we give only till
they're mobilized.
1 week.
Yeah, 1 week or still they're mobilized. If they're walking about well, even after 4 or 5 days, we stop the prophylaxis.
Okay.
Yeah. Go on, Pooja.
So next is the post-operative fluid and electrolyte therapy. So we should encourage the patient to drink liquids as soon as they're awake and free of nausea. Oral diet should be started within 4 hours after surgery. And intravenous fluids are only given if indicated on POD1, and otherwise it has to be stopped. So in the absence of a fluid loss, we have to give maintenance fluids of 25 to 30 ml per kg per day with 70 to 100 millimole sodium per day along with potassium supplements of up to 1 millimole per kg per day. In normovolemic hypotensive patients, like patients receiving epidural, if they have hypotension and they are normovolemic, start vasopressors. And we must ensure a net near zero fluid and electrolyte balance for the patient. There should not be any over. So what does this large volumes of 0.9% of NS do? It induces hyperchloremic acidosis, it causes interstitial fluid overload, it impairs the renal hemodynamics, it reduces the urinary and water retention, reduces the reduction in renal blood flow and glomerular filtration rate. Can somebody define oliguria for me, please? Nikita?
Ma'am, less than 1 ml per kg per hour is oliguria, ma'am.
0.5 to 1. So
0.5.
Yes.
Actually, it is half an ml. Okay, 0.5 ml per kg per hour.
Or less than 500 ml over the day. So over 48 hours, the urine output or oliguria, we cannot, they are not reliable indicators of hypovolemia. Why so? Because as a response to metabolic response to surgery.
One sec, Pooja.
Yes.
All right. Tell me, Nikita, what hormone is produced as a metabolic response that makes this unreliable indicator, urine output?
Stress hormones are cortisol.
I know. No. You actually
saying
started
something.
You said I think you're right, but you didn't.
Aldosterone.
No. So if you mention all the hormones, then one of them will be right. It is ADH. Antidiuretic hormone. Go on, Pooja. Yeah.
Yes, sir. So what happens is in post-operative period, there is vasoconstriction and there is physiological salt and water retention. So basically, urine output and oliguria are not reliable indicators in immediate first 48 hours after surgery. So if the patient does not show evident signs of hypovolemia like hypotension, tachycardia, confusion sweating, we can measure average urine output over 4 hours. And it is best to allow a lower urine output in the perioperative period because it results in significantly reduced administration of IV. Now, coming to urinary drainage, it is only done to prevent urinary retention and to monitor urine output. It is directly related to the risk of UTI. Hence, early removal is encouraged unless and until indicated, like in pelvic surgeries. We have to keep it for a longer duration. And if patients are having, like, if we predict patients to keep urinary catheter for more than 5 days, it is best to have a suprapubic tube or clean intermittent catheterization. Now, coming to the next topic, prevention of post-operative ERAS. It is a major contributor to the patient's discomfort, delayed discharge, and increased cost. How do we prevent it? By minimal usage of opioid, use of minimal access surgeries, minimally invasive surgeries, eliminating routine NG tube placement, and maintaining a fluid balance. Also, peripherally acting mu opioid receptors like almi-wapan and naltrexone can be used. They reduce the opioid-induced bowel dysfunction because they act only peripherally, not centrally. Now, next is chewing gum. So before, in the previous guidelines, they mentioned usage of, like, it can help in mild reduction of EDS, but it shows very limited evidence since they have removed it from the current guidelines. We can also use laxatives and coffee. Laxatives like bisacodyl, oral magnesium oxide, and oral daikenchuto. It's a Japanese herbal medicine that was used in gastrectomy patients. Now, coming to post-operative glycemic control. So what happens after surgery? The patient develops an insulin resistance. It is known as pseudo-diabetes of injury, and it persists over several weeks. And because of this, there is an osmotic shift of fluid into the vascular space and increased availability of glucose, which in turn causes hyperglycemia. Now, what are the interventions that can be helpful to blunt this insulin resistance? We can give preoperative carbohydrate loading, minimal invasive surgery, and thoracic epidural analgesia. And patients who have post-operative persistent hyperglycemia, those are patients who have been found to have a preoperative high HbA1c. So in such patients, insulin should be judiciously used to maintain glucose levels. Now, coming to post-operative nutritional care, early resumption of normal diet is highly recommended. We can give low residue diet than a oral liquid diet, and it is associated with less nausea, faster return of bowel function, and shorter hospital stay. Now, next is immunonutrition. So what happens after surgery? Because of the surgical stress, there is decrease in the arginine, which in turn decreases the T cell function and decreases the wound healing. Hence, post-operative period, we can give enteral feeds with immunomodulators like arginine, glutamine, omega-3 fatty acids, nucleotides, which in turn helps reduces the post-operative infective complications and reduces the length of stay. Now coming to the last component, but an essential component, early mobilization. So what happens when the patient is bedridden for a prolonged state? What happens? We get pulmonary complication. It decreases the muscle strength. There are thromboembolic complications, and patient can develop insulin resistant. So these days we do a goal-directed mobilization, which involves the physiotherapist, where a goal is given to the patient per day. It helps in decreases shorter duration of surgical intensive care unit stay and better functional mobility at discharge. Just summarizing, this is just a brief summary. This is one in ERAS in a glioma patient. So first we do a preoperative counseling, then we do a preoperative assessment. After the assessment, we do a we reduce the fasting time, we give carbohydrate loading, and we prehabilitate the patient by giving lung function exercises. Now, once the patient reaches the OT, we avoid hypothermia, we give appropriate fluid management, we resort to a minimal invasive surgery, we give short-acting sedations, antibiotic prophylaxis 60 minutes before the incision, and like Sir said, surgical site infusions or port site infiltration. Now, post-operatively, we ambulate the patient early. We remove the catheter once the need is done. Post-operative nausea and vomiting prophylaxis. Avoid wound drainage if not necessary. Multimodal approach of analgesia, DVT prophylaxis, and early nutrition. Our responsibility does not end when we discharge the patient. We have to keep a follow-up for the patient, and we have to keep a proper discharge criteria and goals for patient post-operatively as well, and we have to religiously review the patient on regular basis.
Pooja?
Yes, sir.
One thing about this immunonutrition, what you said.
Yes,
the
sir.
Immunonutrition does reduce the length of stay in ICU, but not length
Yes,
of
sir.
stay in the hospital.
Yes,
And
sir.
second thing is it reduces the rate of complications, but does not have any effect on mortality.
Yes, sir.
And I think the initial criticism for the ERAS program was that there were a lot of readmissions. If you discharge these patients early, there were a lot of readmissions, but that theory has been debunked. I think what you said is right about having good counseling of these patients and regular visits home, which may be difficult in this country, but in Western countries they use that, and that helps to reduce the readmission to the hospital.
All right, Pooja. Yeah, good. Okay. I think you
Thank you,
did a very good job, Pooja. Congratulations.
Thank you, sir.
May I invite comments from our guests, please? Is Shrikant still there? Ramkrishna, your comments, please.
Yes, sir. Good presentation. I got a little confused about that catheterization. ERAS recommends routine catheterization in all cases or only when specifically indicated?
Only when specifically indicated, sir.
Because you showed some advantage and all those things, it gave an impression that all the cases we must catheterize.
No, sir. In fact, early removal of catheter is recommended if it is catheterized at all.
Allah, that's right.
Catheterization is not recommended, sir. Neither NG tube nor
recommended.
catheterization is recommended. But
because that presentation, we got an impression like that. That's why I mentioned that.
Yeah.
Otherwise, good presentations.
Right. Shrikant, are you there? I'm trying to reach you. Maybe you can't hear us. I don't know. It doesn't seem to be there. Okay. Niranjan? Niranjan, are you there? All right. Nishant, your comments.
Pooja, first and foremost, congratulations. Wonderful class. I actually learned a lot, like a really lot. It was a very nice class and nothing more to add from my side, sir.
Yeah, he mentions that if 75% of this policy is followed, it's adequate. It's true. 100% of this is not possible. And as a very practical demonstration, we at the moment we have a patient on whom we did a laparoscopic left colectomy for a sigmoid cancer 3 days ago. Today is the third post-op day, and the guy is on full liquids. Tomorrow we hope to put him on solids and actually send him home. Okay, we follow a lot of these ERAS protocols. There are 2 or 3 things which we do not routinely follow. One of them is this carbohydrate load. It is very easy to do it, and I'm sure we will do it. It's just a matter of laziness. I'm sure next time we will definitely give them a carbohydrate load. The rest of it, extensive counseling goes on. We give them extensive advice about pre-op physio, and we sort of counsel them to be very active in the post-op phase, in the pre-op counseling. So they're geared for early mobilization, and all that is done. So except for the carbohydrate load, all the pre-op workup is done. Intra-op, we do not have a total control on the fluid intake. Sometimes our anesthetists, while we're busy operating, even though we discuss it with them, sometimes we may end up having a little more fluids than we ideally would like. Likewise, use of narcotics. Sometimes they, as a routine, they use narcotic analgesics. And so they end up, this particular patient, for example, ended up having a fentanyl patch for analgesia. And, I kept saying we should take it. We did take it out eventually, but for some time during the intra-op phase, he had a fentanyl patch. Post-op mobilization, everything went well, but he went into acute retention. And so because he had a pre-op prostatism, he had a high post-op, high post-void residue. So we were sort of anticipating a retention of urine. And we had actually given him Urimax, but he still had a retention. So even though it is not against the ERAS protocol, it's not usual to catheterize them, but this patient has ended up with a catheter, and he's mobilizing with the catheter. So I think ERAS is a very doable proposition, and all of us, I think, should take it up. Final comments, Abdul, I need your comments too. Yeah.
Sir, nice class, sir. And learned a lot through that.
All right, Nishant, your hand is up.
Sir, just one point regarding this post-op. Do they weigh the patient every day to look for fluid overload? I don't think I saw that point. Is it a component of ERAS or not?
Weighing is not a component. If the patient is, if you have the intake output chart, if you're not in positive balance, and if you've dried them out well, it's pretty good. Yeah.
Okay. So just a point for the students. If you saw that you're supposed to give only 25 ml per kg per day, it's not per hour. So which comes up to about 1.8 liters in a day. And please remember, this includes your analgesics and antibiotics. That itself will usually take up 1 liter. So make sure you don't overload the patient.
Particularly this patient who's in the ward, we had reduced his fluid intake from the first day onwards to about 75 ml. I think the very first day he had 100 ml because he had very little orally, even though we had allowed it. But the second post-op day, when he started taking some oral liquids, we reduced it to 75 ml per hour. So that would be the kind of fluid that you give. And as Pooja pointed out, make sure that you don't give too much sodium. As I said, using 5% dextro, normal saline, 0.9% normal saline or Ringer's lactate continuously can add a lot of sodium to the patient's electrolyte load. So be careful about that. Ravi, your final comments before we close.
I think I was fortunate to listen to Henrik Kellett when he first presented the ERAS thing in 2004, Association of Coloproctology. I think that though he did all his work, but that was the first plenary session, 1 hour lecture. And that is when I think this was one of these I was there kind of moment. And I think it is a culmination and a combination of many evidence-based surgery which has come into force since then, I think. Because till then it was all, the evidence was not used properly. I think since then it has been used properly. We in fact implemented this in North Manchester University Hospital, saved the trust 200,000 pounds in the first year of its implementation.
Yeah.
Very, very good, but it has to be multi team approach. include the anesthetists, the ward sisters, the nutritionists, dietitian, everybody, then it can be implemented properly.
Yeah. Srikanth has put a note, even though he didn't talk, that he feels that an anesthetist also should be involved in these discussions. Point well taken. I think we should involve them as well in the active pursuit of introducing an ERAS program in our hospitals. I think we had
excellent lecture, Pooja. Very well done.
We've had a very good
Thank you,
session. Again, well done, Pooja, and good night to all of you.
Good night, sir. Class is at 8:30 tomorrow, live, I think it is. Isn't it, sir?
Yes, sir.
What is
Yes, sir. In conference hall, sir. The guest lecture, sir.
in the morning, 8:30 tomorrow. Correct.
But yeah, again, there was a this one saying it is online. That is why I was a bit.
It is not online.
No, sir. It's not an online session, sir.
But if you look at this one put up, it says online.
No,
sir,
Ravi, what happens is even with a physical class, we
Zoom
record it. For recording, we do have a Zoom. So
okay.
if it says 8:30 a.m., it is a physical class. And if it's 9 p.m., it is an online class.
Okay.
All right. Good night, everybody.
Good night.